Hello, everyone. I'm Dr. Carmen Puliafito here with Retina Synthesis, and our guest today is Dr. Yasha Modi, who is Associate Professor of Ophthalmology at the New York University Langone Medical Center in New York City. Yasha, welcome to Retina Synthesis.
Thank you. Thank you. It's just a privilege to be here. And, we're going to be talking a little bit about a retinal vein occlusion, and I'm excited to have this conversation.
So there's been lots of evidence from the both publicly funded and privately funded research, clinical research on vein occlusion. But let's talk a little bit about some basics before we get into therapeutics, and that is evaluation of the eye. In patients with branch occlusion, vein occlusion, what is your ophthalmic and medical assessment of these patients?
Well, I think it always starts with vision and pressure. I think it's really, really important to know their vision because that's oftentimes the best prognostic factor for how they'll do at 1 month, 6 months, and a year. Then pressure gives you some understanding, especially if there's asymmetry in pressure, as to whether or not there may be signs for neovascularization of the angle. And that's a really, really important cue that you can use just before you even see the patient. And then, of course, a good evaluation of the iris, and then also an examination of the retina. And, we know the classic features. If there's a CRVO, you can have disc edema. You can have hemorrhages in all 4 quadrants. And then there's sort of the venous dilation and tortuosity that is sort of the classic picture. I think the acute findings of retinal vein occlusion, CRVO and BRVO, I feel like first-year residents can nail it immediately. The hard part is actually when they become chronic. And then all of the hemorrhages go away, all of the disc edema goes away, the tortuosity improves somewhat. And then you really have to use vascular remodeling as sort of the guides to help you. So if you're, in one way that's really, really helpful is actually looking at a red-free that allows you to understand vessels crossing the raphe, and then also OCTA, if it's available, is a really, really cool tool to help understand anastomoses.
So if you have an eye with a branch or hemi or central vein occlusion, do you do fluorescein angiography, OCT angiography, wide field OCT fluorescein angiography? What do you do?
I think that's a great question. I sort of I put on 2 hats when I answer this question. I think hat 1 is I'm a practical clinician, and I know if they have macular edema, I'm going to treat to that endpoint. And so therefore, maybe imaging outside of an OCT is not that necessary. On the other hand, I am a full-time academic at NYU. So my brain wants to know a couple of things. I want to understand the extent of non-perfusion. And there's some really, really great papers looking at the sort of what was called the ocular ischemic index, where essentially this is ultra wide field imaging. So you get very, very broad areas of the retina. And what we know is that the more ischemic the ratio is, the more ischemic the areas of non-perfusion to the total area of retina, the more likely they are to go on to neovascularization. So that's sort of a prognostic factor. It helps me talk to the patient about compliance. It helps me start to understand the disease a little bit more. Think about like the BVOS and the CVOS, right? The definition of ischemic was 5 disc diameters of non-perfusion in the BVOS and 10 in the CVOS. Well, what we're starting to see on ultra wide field imaging is like 40, 60, 100 disc diameters of non-perfusion. That's a totally different ballgame. And having that insight, I think, just provides me more information. So the answer is almost overwhelmingly, I do get a fluorescein angiogram, but I also recognize that practically, especially if I'm treating macular edema, it's not necessary.
So will you use the Optos wide field angiogram as your preferred tool or not?
Yes, and I love that for essentially all retinal vascular disease. A diabetic disease, retinal vein occlusion, it provides you the most incredible wealth of information. We learned that a little bit in diabetic disease with predominantly peripheral lesions as a way to, potentially identify more severe forms of DR. So I started using it for that tool. And then I started now using it more for understanding basically the ocular ischemic ratio, like that we're talking about, this index ratio for non-perfusion and retinal vein occlusion.
What about medical evaluation?
It's a great question. So first, low-hanging fruit, right? What's their age, right? And I think that so I sort of break this down as to 50 and younger and 50 and older. And so the paradigm is if they're 50 and older, if they have high blood pressure, hyperlipidemia, diabetes, if they have glaucoma, those are all risk factors for RVO. And in my opinion, I don't think those individuals need necessarily a workup. On the other hand, what if you have a 25-year-old who now has a CRVO? It's a pretty unusual circumstance, right? And so those are individuals where good medical history is important. You want to understand if they had, prior DVTs, any spontaneous miscarriages. You want to look for inborn causes of hypercoagulability, and that can be done, if you have a sort of a smart phrase, an EPIC, where you can draw some blood, or if you can link to a really good hematologist that you trust and has some understanding of CRVO and what they're looking for.
Mhm. What about going back to imaging for a moment? What's the role of OCT angiography in these eyes?
Yeah, so that's a really great question, and I think for me, I use OCT angiography in those circumstances where maybe there's a branch retinal vein occlusion that occurred a few years ago, and maybe they come in with a sort of a minor vitreous hemorrhage, but I really can't see well enough to understand what's the driver of that vitreous hemorrhage. Sometimes OCT angiography can help me see collaterals. And then if I know if I have collaterals, then I know very likely, sort of distal to that, I'm likely to have some NVE, some neovascularization that's driving the hemorrhage. So I love the use of OCT angiography for collaterals. Unfortunately, like many diseases like diabetic retinopathy and retinal vein occlusion, we would sort of think of maybe if you had enlargement of the foveal avascular zone, that would portend a poor prognostic factor. But there's not a good linear correlation between size of the FAZ and vision. Obviously, if it's massively enlarged, then there's going to be a significant decline in vision, but it's not a linear relationship. So good for diagnostic value, not so much at the moment for prognostic value.
Mhm. So now that we've made our diagnosis, let's talk about management of branch vein occlusion to begin with.
Yeah.
What are your indications for treatment? Let's say the patient comes in, has a vein occlusion, vision's 20/15.
Mhm.
I noted a little bit of visual field change, but their central acuity is perfect.
Yeah.
Are you going to treat that patient?
That's a watch patient. Those are people that we watch. And I think this is the patient where I love fluorescein angiogram, especially ultra wide field FA, because what you're trying to do is understand how they lose vision. And if you understand the degree of ischemia or non-perfusion, that will help you understand what's their likelihood of progression onto neovascularization. So that's sort of really important for me at this point. But this is observation. And the more ischemic it is, the more concerned I am and the closer I'm following these patients.
Mhm. So, what are your indications for starting treatment in branch vein occlusion? How do you treat the patient, and
Yeah. So
what's your
essentially,
regimen?
symptomatic macular edema. And almost always they're symptomatic if it's foveal involving, right? So center involving macular edema is really what we're looking at for treatment. And I think from the SCORE2 study, my go-to is using bevacizumab as first line. And then typically, especially if it's acute disease, we understand very, very quickly whether they're going to have a response to it. So the vast majority of individuals do have a positive response. And then on the other hand, if they don't have a positive response, or if they can't get out to a long enough treatment interval, then we can try a more potent anti-VEGF like Eylea. And then if we don't have a response even then the final sort of solution would be moving on to a steroid, something like a intravitreal dexamethasone implant.
Mhm. What's your treatment interval to begin with
Every
bevacizumab?
4 weeks, every 4 weeks. And I understand that, some of my colleagues will actually try to do every 5, especially if they're worried about trying to get in on the 28-day window. But I'm very much of a purist. I really just start every 4 weeks and then I extend beyond that.
And how long do you keep the every 4 weeks going?
So I started treat and extend immediately. So for those who are familiar with the SCORE2, the SCORE2 actually study was looking at bevacizumab versus aflibercept. And for the first 6 months, they were getting monthly therapy. But what's interesting about the SCORE2 study is not so much the first 6 months, in my opinion, but rather the latter 6 months. And in those groups, they had, for those who responded well in the first 6 months, they basically were on a standing treatment versus a treat and extend. And what we learned in that window is that treat and extend does very, very well for maintaining the gains that they had gained in the monthly window. So while we don't have really solid evidence showing that initial treat and extend makes sense, I think that's a very, very reasonable way to go about following these patients in clinical practice that provides a good compromise between sort of efficacy and then managing sort of patient expectations and number of visits and trying to sort of maximize their time away from the clinic.
Mhm. Let's move on to talking about central vein occlusion now. You talked about the SCORE2 trial.
Yeah.
Can you tell us a little bit about the SCORE2 trial?
Yeah, so it was a NEI-funded trial, and this was a study looking, in the beginning, it was a few hundred patients, and it looked at patients, it randomized patients who either had a CRVO or HRVO, and it sort of lumped those two together, and they either received Avastin or Eylea. And it was monthly for the first 6 months. And then that was the primary outcome. It was a non-inferiority study looking at visual acuity at 6 months. And what they had determined was that bevacizumab was non-inferior to aflibercept. So that's sort of the language that they use. So in non-inferiority studies means you have to, at the end, is one going to be inferior to the other? That's the outcome. And so it didn't hit that endpoint. So that's why the kind of unusual language per se, that maybe for those who are not familiar with clinical trials, as to why it says non-inferior rather than saying it's not superior. But anyways, you move on from this 6 months. There were then 3 arms to each of those groups. So in the bevacizumab arm, after 6 months, they kind of broke down into three groups based on whether they were a good responder or a poor responder. So say somebody has no macular edema, they're doing great. So half of those patients were put on to monthly, they continued on monthly in their respective arm. So if they were getting bevacizumab, they continued to get it. If they had aflibercept, they continued to get aflibercept. And then they were either then going into the monthly or the treat and extend arm. But the real interesting arm in both of these was what happens if they did poorly. And so if essentially aflibercept patients did poorly, they're given the opportunity to switch to intravitreal dexamethasone. And if patients were doing poorly in the bevacizumab arm, they were given the opportunity to get aflibercept. And so what happened in the last 6 months was something that was kind of interesting. So the treat and extend patients did just as well as the monthly patients, but they received fewer injections, as you would imagine. The aflibercept arm received marginally fewer injections in the treat and extend than the bevacizumab, meaning probably they were at a longer treatment interval at the end of it. And then for those who didn't do well, whether they were switched from bevacizumab to aflibercept or aflibercept to dexamethasone, they both did well. Both groups did well. But the numbers that actually fulfilled that criteria of poor responders was so small that they weren't able to make any statistical inferences. So what that says is that the overwhelming number of people do very, very well with anti-VEGF therapy. And the SCORE2 kind of provides you an interesting clinical framework on how to progress. So say you're like me, you start with bevacizumab, very easy to start there, move on to another anti-VEGF, like aflibercept in this case. And then if we're still having a poor response, then you can go on to an intravitreal dexamethasone implant. And I think in RVO, you can kind of make these decisions pretty quickly. So if somebody's not doing well with bevacizumab after about 2 injections, I tend to move on to aflibercept. And again, 2 or 3 injections max. And if they're not doing well with Eylea, then they're moving on to intravitreal dex. And I run through that algorithm pretty quickly. And that's sort of an extrapolated algorithm that I've come up with from basically SCORE2.
So how long do patients with vein occlusion need to be treated and or monitored?
Yeah, that's like the $1 million question, right? I think we probably all have patients who have CRVO, lost the follow-up for 5 months, they come back and they look awesome. No macular edema, haven't needed treatment, no neovascularization. And then we keep watching them, and then they never need treatment. But they needed it before they were lost to follow-up for like 6 months. And then we have those who literally the moment they go, they're on a treat and extend, and they're on every 8-week injections. And the moment you extend them to 9 weeks, they come back with macular edema, and it endures for years. And so that's the question, right? We don't have an imaging biomarker. We don't have a feature clinically that tells us how long we need to follow these patients. So that's kind of why I like the treat and extend for this reason, is that because it provides us a sense that we're slowly and conservatively extending them out 12 weeks, 14, I'll even go out to 16 weeks. And what I want to know is, are they likely to recur during this window? And if they get out to every like 12 or 16 weeks for a few visits and they don't require treatment, then we'll observe them, you know? And I think, Rishi Singh has always sort of talked about, well, maybe we're over treating a lot of these patients. Maybe we should just be on a PRN basis up front, because some people just don't need that level of intensity. And I think that's a very reasonable strategy as well. So this sort of goes into that art of medicine, right? We don't have a great treatment paradigm. It's not like one paradigm is better than other, but what we know is that we just have to kind of follow patients closely, and patients also need to be aware of any changes in their vision, meaning monocular testing, covering one eye, covering the other eye, testing their vision regularly, and then being responsive with that. If they worsen, that they come back for treatment.
You talked a little bit about the use of the dexamethasone implant.
Yeah.
How frequently do you use it, and what is your typical scenario in which you would use it?
Yeah, so that's a great question. I've really noticed. I went back, and somebody had asked me this question, so I went back and actually looked at my utilization of dexamethasone not too long ago. I almost never use it in BRVO, which is kind of interesting. I was surprised by that, and I use it quite frequently in CRVO. And the interesting thing is, a lot of the patients where I'm using it, they're either patients who've required long-term treatment and they keep recurring and they want to get out to a longer interval, or they're individuals who have just basically disease that is chronic or severe enough that they're not responding to anti-VEGF therapy. And I would say that that's not a trivial number of patients. That's probably somewhere around 20 to 30% of my CRVO patients, which was kind of more than I had anticipated to be.
So in the Regeneron clinical trials, there was a lot of emphasis placed on early treatment.
Yeah.
And there was some tendency in the distant past of observing patients for a while.
Yeah.
But if a patient's, this is an urgent scenario, correct?
This is something where I would say urgent in the sense that they ought to be treated probably within a week or so of their diagnosis, correct? And we get this information from the registration trials that approved Lucentis and Eylea for the treatment of RVO, because there was a sham group. And so what we learned actually in DME, RVO, AMD across the board, that if we wait a window of time, whether it's 6 months or a year, and then we switch them over into the treatment arm, well, that arm doesn't do as well as if they had received treatment right up front. So there is a penalty to delaying treatment. And so as a result, we don't follow the old BVOS guidelines that said, hey, wait a few months to let the hemorrhages clear. And if you think about it, it makes sense, right? The reason why in the BVOS they were waiting till the hemorrhages to clear is because they're doing focal laser. And so, but anti-VEGF isn't predicated on good visualization of the macula. And so therefore it allowed for immediate upfront treatment. And we learned that delayed treatment actually was costly.
Mm-hmm. Is there any room for laser in the treatment of branch vein occlusion anymore?
So that's a great question. I suspect that the answer in the modern era is probably no. But the BVOS demonstrated a benefit in patients who are receiving focal laser, but we know that there's no benefit in CRVO. I can't think of a retina specialist in the modern era who does focal laser for BRVO at this point in time, though.
Mhm. What about management of neovascular iris neovascularization and neovascular glaucoma?
Yeah.
Uh, what's your approach to an eye with these findings?
Yeah. So the first step in those cases is always anti-VEGF. And so the anti-VEGF has an incredibly fast regression of neovascularization, and the goal is really to get it out of the angle. And so when we think about NVG, we really kind of want to break NVG down into three grades. Grade 1 is basically NVA with an open angle. Grade 2 is essentially NVA with some intermittent peripheral anterior synechia. And then grade 3 is essentially neovascularization with a totally shut angle. And this is an important thing to differentiate, which means that retina specialists do need to hold on to their gonioscopy lenses. And the reason why it's valuable is because for grade 1, I'm almost always managing them myself. I don't need to get glaucoma involved because I know the moment I get the anti-VEGF on board, I'm very likely to have a pressure reduction with that plus topical drops. Grade 2, it's a bit mixed. You'll win some, you'll lose some, and some will need to go onto tube. And then grade 3, they uniformly go onto tube. So we can use that as a stratification for helping us understand their likelihood of progressing onto needing glaucoma drainage implant. And then, of course, anytime you do anti-VEGF, you have to realize that's a transient treatment of their neovascularization. So it has to be followed up with a very thorough PRP. So these are individuals, especially with CRVO, where I do essentially PRP starting relatively posterior. I try to use the FA to guide and make sure I'm treating all the areas of non-perfusion. And I'll actually take it all the way up to the aura in these cases. Because I've noticed that even after a good PRP, the neovascularization can return.
What about brolucizumab for vein occlusion?
Yeah, so it's not FDA approved at this point. And actually, interestingly, Novartis had ceased their program for retinal vein occlusion. So it won't be an approved indication for it. And so I think this is something that we just won't be using it for.
Hmm. It's intriguing. It's a very powerful anti-VEGF agent.
Yeah, it certainly is. But like with every, there's always a risk benefit analysis, right? And if you have a gold standard, which is essentially the three anti-VEGFs that we have, two on label, one off label, that have set a track record of over a decade and a half of safety. It's really hard to argue with that, where if you're having rare circumstances where there are circumstances where they may lose vision permanently as a direct result of the drug, it becomes difficult for practitioners to consider that as first line or second line. So you could say, well, certainly if Novartis went through the pipeline and said, hey, we're going to go ahead and do this study and we're going to try and make it such that we get it indicated for RVO. Well, if you failed all of your other anti-VEGFs and dexamethasone, certainly I think it makes a lot of sense to have it in the toolbox. But it's just not going to be, because I think their IOI rates were just too high in those studies.
Well, Yasha, thanks so much for joining us on Retina Synthesis and sharing with us your experience with management of vein occlusion. It's certainly changed a lot in the last several decades.
Yeah, and it's a fascinating thing. And we were talking earlier before this started about the crazy part is there's the old and then there's the new, and we're doing all of this new research on sort of prognostication. And it turns out probably the best prognostic factor is visual acuity at presentation. So there's always a room for understanding the history of where we are, and then also for trying to come up with new theories and new research ideas.
Well, thanks again, Yasha.
Dr. Pulafito, thank you so much. It's been my pleasure.